Hello and welcome to the Wisconsin Society of Cytology Spring Meeting 2019. I would like to thank all of our members who have joined us live. Just letting you know that if you are not joining us live, you probably won't be hearing this, but everybody will be able to download this entire talk afterwards. It's being recorded. Let's move along. So our speakers today will be Dr. Kaitlin Sundling. Dr. Kaitlin Sundling is the Wisconsin State Laboratory of Hygiene's clinical instructor for the School of Cytotechnology, as well as the faculty director. She is also at the UW School of Medicine and Public Health, working as a cytopathologist, member ASC, USCAP, and WSC as well for going on 2 years now, I'd say. And she'll be talking on the subject of serous fluids today. Joining us today as well is John Shalkham, who is currently at the Wisconsin State Laboratory of Hygiene wearing an awesome hat as Clinical Assistant Professor Emeritus, member ASC, ASCP, ASCT, and WSC for much longer, I'm sure, than I have been with the organization. Quickly introduce myself. This is Josh Fulks, your webmaster and MC for this online meeting. For those of you who are not familiar with GoToWebinar software, you'll be able to ask questions. There should be a questions bar in the little sidebar, which you should be able to hide if you want to with the yellow arrow on the top. I'd like to talk briefly about the industry support that we are receiving to put on this talk. The Wisconsin State Laboratory of Hygiene, especially the Office of Information Services, was generous enough to provide us with all of the equipment that we need, set us up with. Jim Hermanson over here spent a great deal of time setting up all this equipment last night. I'm sure several sleepless nights thinking about, just one sleepless night, thinking about how we're going to put it together. And we'll move along to our sponsors, starting with Roche. Anna Margaret Callender, as many of you know, is a great resource for those of us who utilize Roche products. I'd just like to plug their website, which I haven't looked at in a couple of years, but they have an excellent educational section in there under their research and development area. They do these neat little cartoons. One of these, Paul Ehrlich, I'm not sure if you're familiar, Nobel Prize for, I believe, protein targeting, a long time ago. And just really neat animations and resources to look at. We also have Newcomer Supply, who's supporting us. They are a local to the Dane County area supply company for histology, and they are just now starting to get into cytology. So take a look at their website. All of these links will be clickable in the downloaded version. Sakura as well is supporting us. Right here, I have to make a personal plug. We utilize the Sakura Glass G2 in our own laboratory. We love it. When it works, it takes away a lot of our throughput time. So just a personal plug. And Angela, whose information is at the bottom, has been more than helpful in the past. Hologic is also supporting us at the platinum level. So you'll get another message about them during the break. Katie Hughes has been an invaluable resource to us, and she's always pulling for the society. She puts a lot of pressure, I'm told, on the finance folks to give so that we can put these kind of things on. So without further ado, we'd like to move along to our talk with Kaitlin, and I will do some of the technical stuff to get that.
All right, first of all, I would just like to thank you for having me. So I actually presented for the Wisconsin Society of Cytology about 2 years ago when I was still a resident, and that was such a wonderful opportunity. So I really appreciate the chance to come back, and I really want to continue this relationship. It's a wonderful society, and I think this is a great new format for us to try out, and I hope that you'll like it. So today I'm going to be talking with you about serous fluids. I'm going to show you some challenging cases that I've had recently, and I'm going to show you some of the approaches that I used both in my fellowship training and in my current clinical practice. And then just a few notes about the future, some emerging technologies that are on the horizon. So Moving into our learning objectives, I'll just put them up there and you can take a look at those, just a little map of where we're going. Moving into our first case, our patient is a woman in her 80s. She presents with a pelvic mass and a history of a hysterectomy. And in some of these cases, I've censored a little bit of the clinical history just to make the cases a little more educational, just as an FYI. So we're looking here at a pelvic washing. So here's the thin prep of that pelvic washing. So here you can see some sheets of cells that are relatively evenly spaced. They have some round nuclei, a little bit of grooving in some of the nuclei, some pinpoint nucleoli, and then some other sheets with a little bit more shrunken nuclei, but still very even, regular spacing and windowing in between the cells. So here's a higher power of one group that was on the thin prep slide, a little hint of a space here between the cytoplasmic borders, but again, very round nuclei. So these are sort of the summary of the findings that we saw on the thin prep. But on these cases, we do prepare cell blocks. So I just want to briefly overview the methods that are available for cell blocks. Just to give you some ideas, maybe you haven't heard of some of these before, or maybe you do use some of these in your own lab. So probably one of the simplest methods that can be used for a cell block is the coagulum method. So coagulum method is one of the simplest techniques. So this is really just allowing the specimen to clot directly on a glass slide or filter paper, then fixing it in formalin and processing it as you would a small biopsy or other tissue specimen. So this kind of depends on having some natural coagulation factors in the specimen, and sometimes our fluids may or may not have that ability to sort of clot on the slide. Some of the other methods that involve a little bit more preparation is the histogel method. So that involves mixing a gel with the cells, the cell pellet after you've spun down a portion of the fluid. The colloid bag technique is another method I'll show you on an upcoming slide. And then there are some other methods using a simple cytospin apparatus. In our lab, we've used the plasma thrombin clot method, as well as the histogel, or the sort of newer iteration of that histogel method, the cell gel method. And then the Celliant method is a little bit newer technology that I'll show you here. So on the upper left, you can see the plasma thrombin clot method. So you take a falcon tube with your fluid in it and spin that down. We recommend starting with about 75 to 100 milliliters of the fluid. And you spin that down, decant off the supernatant, and then you take your cell button and mix it with a plasma and then thrombin to form a clot, and mixing those together catches all the cells into that clot, and then you can take the clot and process that as you would a small biopsy, usually wrapping it in something so that the fragile clot won't break up during processing. The next method that is a little bit higher, sort of higher input, but a very nice method because it doesn't introduce any extraneous material within the sort of substance of the cell block, is the colloid bag method. So this actually involves creating a polymer that polymerizes around the inside of your vessel. So you could do this in a falcon tube or other container. So then when you spin down your cell pellet within that tube, it's actually wrapped in this fluid permeable bag. So when you remove that bag, actually the liquid component is sort of left behind, and your cells are separated out without introducing, plasma or any gel in between the cells. So that's a really nice method for concentrating your cells and sort of keeping them cohesively within that bag. And the bag can actually be processed and cut by histology. It doesn't have to be removed in processing. So then on the lower left, I'm showing the Celliant technique, which requires some instrumentation, and it requires a little bit of extra materials here, but this is actually a 100% alcohol fixation-based technique. So this is actually an alcohol-fixed paraffin-embedded cell block. And these blocks are processed one at a time within the instrument from a thin prep vial. So This is a really clean technique, and it produces really nice morphology on the cell block, but it's important to be aware that it is fully alcohol fixed. So if you're doing immunohistochemical stains that depend on formalin fixation, this method may require revalidation of those stains. That's something to keep in mind whenever you're processing cytology specimens. If your specimen is exposed to alcohol, that may change the way your stains respond. You might end up with false positives or false negatives. One additional technique I just wanted to tell you about, this is the cytospin-based method that I mentioned. This basically involves using a cytospin apparatus to spin, to sort of cytocentrifuge your cells into a little well in a foam receptacle. So this also nicely concentrates your cells and doesn't introduce any foreign material in between your cells. But really the most common techniques are probably the plasma thrombin clot method. That's sort of cheap and easily available. You can just use expired plasma, for example, from the blood bank, or some of the histogel-based methods. There are a lot of options available, and we've at UW Hospital we've used the plasma thrombin clot method as well as histogel. So here's our cell block. So I've mentioned this is a really nice way to concentrate cells. So even when you have a very paucicellular fluid, you can sometimes see additional findings in your cell block that you didn't see in your thin prep slide. So in our case here, this 80-year-old woman, we saw those sort of bland looking cells on the thin prep, but then on the cell block, we saw these more concerning looking cells. So this is a low power view that gives you an idea of the scale of these cells. There are some white blood cells here in the background for size and some of the red blood cells here. And this is a super high power view, kind of the cells that ate Manhattan here. So what I believe is going on here is that we have two cells, one nucleus here, although it's a bit hard to tell the borders between the cells. We have a very irregular nucleus here and a large nucleolus that's a little bit irregular. And then here we have a large nucleus, very high NC ratio, and a very prominent nucleolus. So I'll just give you a moment to think about what would your diagnosis be in this case, and would you do any additional workup? Considering that it's quite paucicellular, but given that we have a cell block, we could cut additional levels and potentially do some additional stains. All right, moving on to our next case. So this is case 2. I have 4 cases that I'm going to show you. So our second case here is a 64-year-old woman who presents with an ovarian mass. And again, we see a pelvic washing. So this is our thin prep slide here. So here's a nice low power view that shows you this is fairly cellular. You have a mix of some inflammatory cells in the background. And then here we have these sheets of cells that have a little bit less cytoplasm than what we saw in the previous case on the thin prep, but still have round nuclei and sort of pinpoint slightly distinct nucleoli. And then over here, we're starting to see those similar looking cells that are kind of clustering a bit more and maybe having a little bit, at least the appearance of a higher nucleus to cytoplasm ratio. Now on our cell block, we have a couple of different features. So again, this is a very high power view, 100x under oil. And here we see some large cells that are actually somewhat distinct in these little spaces or lacunae. And they have a fair amount of cytoplasm, but a relatively round, slightly enlarged nucleus and a little pinpoint nucleolus, almost kind of a rhabdoid appearance to some of these cells. On the other hand, in other places, we have cells that are a little more bland, again, round nuclei, pinpoint nucleoli, but clearly appearing in these strips. So we have kind of these single cells that are a little bit more dispersed, and then these strips of cells that are not unusual to see in a pelvic washing. So again, think about what your diagnosis would be, and would you do any additional workup in this case? Our third case, this is a 57-year-old woman with a history of an invasive ductal carcinoma, first diagnosed a couple of years ago, now presenting with a new left pleural effusion. So here's a low power view of that pleural effusion, the thin prep slide. And you can see there are a couple of different types of groups going on. We have these more heterogeneous clumps that were mostly composed of macrophages and some mesothelial cells that looked less concerning. And then we had these groups here that were just a little bit larger cells, a little bit more monomorphic look within these groups. So here's a higher power view of those groups. You can see the larger nuclei, although they are still round. The cells are sort of more clustered, they're not as evenly spaced, and you do see some nucleoli in these groups. Here's another group. I've really turned up the brightness here so you can hopefully see around the edge especially that there are some fairly prominent nucleoli in this group. And then if you look in the center, there are prominent nucleoli as well. And this is a very sort of clustered, crowded group that we were concerned about. And here's another group that most of these cells, I would say, were less concerning, more bland looking. And then we have a nice little mitotic figure there. So we did prepare a cell block in this case, and by and large, we had inflammatory cells in the background and some clusters of macrophages and a few mesothelial cells, but then there were rare groups that were like this that were just a little bit indeterminate in their features. So they have mostly round nuclei, but you can start to see a little bit of a slightly reddish nucleolus in this cell, and then a little bit of a distinction between cells or a space between cells. So a little bit of mixed features in these groups. So again, we'll talk later about the potential diagnoses and the workup that was done in this case. And our last case, this is a 66-year-old woman with a history of non-small cell lung carcinoma, diagnosed a couple of years ago. And she had pleural and pericardial effusions at the time of diagnosis that by cytology were negative for malignancy. She presents now with a right pleural effusion and a PET positive level 2L lymph node. So we got the pleural fluid, and here you can see on the thin prep, it's pretty paucicellular. You have this proteinaceous background, and some inflammatory cells sprinkled in there. Are they coming from blood, or are they intrinsic to the specimen? Not even a lot of mesothelial cells that we could sort of definitively identify. And then we had this cluster of cells. And you can tell a little bit from this low power view that this is actually right on the edge of the circle of the thin prep. So we would expect to see some air dry or sort of blown up look of these cells. So we have to take that into account when we're evaluating them. But we do see larger nuclei, although the nuclei are fairly round. And there are some sort of pinpoint, I guess I would call these chromocenters. I'm not sure that they're truly nucleoli. So again, we have a cell block on this case, and by and large, we're seeing rare cells that sort of mimic what we see on the thin prep, mostly looking like macrophages, rare mesothelial looking cells, and then we have very rare atypical looking cells with very hyperchromatic nuclei and a little bit of vacuolization to the cytoplasm. So again, this is a case we'll come back to at the end of the presentation. So I'm going to give you some ideas of how to work up these cases, and we'll talk a little bit more. So as most of you and probably all of you know, when these classic morphologic features are present, we can really distinguish between mesothelial cells and adenocarcinoma, and that's often our differential diagnosis in looking at these cases. Are these cells reactive mesothelial cells, or could this be adenocarcinoma? And in certain clinical contexts, we're probably considering could it be mesothelioma as well when we're looking at a fluid. So I'll just review a little bit bit of the classic morphology that you can see that if it were present in all of our cases, we'd have a very easy time diagnosing all of these. So you'll recognize this common finding in a pelvic washing. We have nice sheets of mesothelial cells, and then we have this cluster that the sort of classic, you know, when you're early in your training, you don't want to mistake this for adenocarcinoma. And I think you can recognize this as a collagen ball. So this really has a proteinaceous core and some benign appearing mesothelial cells studding the surface. Now, when mesothelial cells get a bit more reactive and riled up, as we might see them in an effusion, they can start to look a little scarier. So this is a very high power view, again, at like 100x on oil. And we have large nuclei with prominent nucleoli. But we do still have some features that help us identify these as mesothelial cells. So we have a really nice separation between the two cytoplasmic borders of the cells. So a nice window that again represents those microvillus borders that we sort of see that clearing. And then you can sort of imagine a little bit of a lacy skirt around some of these cells. So when those features are present, we can still differentiate between a second population and our background reactive mesothelial cells. So here are two cell populations from two different patients. And I'll just give you a moment to think for yourself, which of these do you think represents adenocarcinoma? So do you think it's the ones on the right or the ones on the left? So I'll say from what I've talked about so far, I haven't really pointed out all of the options, but the ones on the left are actually adenocarcinoma. The one on the right is mesothelioma. So these are, neither of these is reactive mesothelial cells of what I've talked about so far. And so these are kind of the classic features of adenocarcinoma versus mesothelioma that we can sometimes see in these super classic cases. So in adenocarcinoma, we tend to see this smooth community border, which when I was first learning about it, it didn't make a lot of sense to me, but it's kind of like the cells are all getting together and they want to build a fence around their community, and they want to make that fence sort of the smoothest possible one continuous line. So their cytoplasmic edges will come up to meet each other, at least in these very classic cases. Now in mesothelioma, if you have a really classic mesothelioma, these tend to have these scalloped borders or the mulberry appearance to the group. So really you'll see each individual cell jutting out as a rounded protuberance from the cell group. So mesothelioma, classic mulberry groups. Now, when we have ambiguous features between adenocarcinoma and cells of mesothelial origin, whether they are mesothelioma or reactive mesothelial cells, there are some stains that can be helpful. So I've listed here a little bit of a summary. This is not comprehensive, but these are some of the stains that can be used. So on the left, we have the mesothelial stains. The ones that I tend to use and the ones that I'm going to show you in this presentation are WT1 and calretinin. We always have to keep in mind that serous neoplasms express nuclear WT1. So when we see effusions in women, we always have to keep that in the back of our minds. The real pitfall in making this differentiation is that cytokeratins, which are sort of the mainstay of localizing metastatic adenocarcinoma in many other sites, are actually expressed in mesothelial cells. So AE1, AE3 is one of our sort of bread and butter cytokeratins that picks up a lot of carcinomas, but it will also be positive in reactive mesothelial cells, benign mesothelial cells, and mesothelioma. CK7 is the same way. CK5-6 doesn't tend to be expressed in adenocarcinomas, but you have to keep in mind that squamous cell carcinoma is positive for CK5-6. So when you're working up a case that, you know, there may be a lung tumor and maybe it's not that well differentiated, you should definitely keep that in mind. So CK5-6 is positive in mesothelial cells as well as squamous cell carcinoma. And then something just to keep in mind, a lot of cells and tissues can express estrogen receptor, not just breast cancer. So we had one of our cases that was a breast cancer case. So estrogen receptor can be a difficult one to use as a diagnostic stain. So on the right panel here, we have our diagnostic immunohistochemical stains for adenocarcinoma. And the classic ones we think of are MOC31 and BRE-P4. These are definitely useful in some cases. We actually have stopped using them in my clinical practice just because of really low utilization, and we've kind of moved to a more targeted workup. But that can leave us in a little bit of a hard spot when we have a case that's poorly differentiated or an unknown primary because we don't have kind of generic adenocarcinoma markers. But the problem with these is that some mesotheliomas actually can pick up MOC31 and BRE-P4. So the relatively lower specificity of these stains makes the utility a little bit less than a new marker that I'm going to tell you about. So that new marker here is Claudin-4. It's been out for a few years, and I have yet to see a really large-scale study of how Claudin-4 works, but it is very useful in clinical practice. So this is something that I created in fellowship. You can find the paper here in Cancer Cytopathology. My fellowship was at Brigham and Women's Hospital with Dr. Ed Sebas. So this is the workup that we used there at Brigham and Women's Hospital. So we had a really nice dual stain available, which I'll show you some more pictures of, and we had Claudin-4 available. So with the combination of those two tests, we were able to generate this really nice workflow that represents maybe kind of an idealized workflow. It didn't always work out perfectly in this algorithm, but this was sort of our general approach to most cases. So I'll show you a little bit more about those stains. So just a little bit more in detail about Claudin-4. So Claudin-4 participates in tight junction formation. So this is why it's really broadly expressed in cells of epithelial origin. It's involved in those tight junctions. So here it is on the cell membrane, sort of with adhesion between two cells. So you're going to expect this to be a membranous stain. And what's really great about Claudin-4 is that it's really not been reported to be expressed in malignant mesothelioma, which is great, and it's expressed in the vast majority of adenocarcinomas. So this is a really great generic adenocarcinoma marker. It is actually expressed in other carcinomas as well, not just adenocarcinomas, but adenocarcinomas are kind of the most frequent, the sort of have the highest levels of expression. So this is a really nice, both sensitive and specific adenocarcinoma marker that you can use to differentiate. So here's a nice strong membranous expression. You can see this kind of exclusion of the cytoplasm. You see the holes of the blue counter stain of the nuclei, and then a little white of the cytoplasm, and then the dark brown of the Claudin-4 staining. This is a little bit less cellular specimen where you can see a little bit more of the real life, sort of not as strong expression of Claudin-4 that we see in some of our adenocarcinoma cases where you have small clusters of cells, but still a nice crisp membranous stain. And then no expression in mesothelioma seen here. Here's a really nice example of Claudin-4 here on the right. This was an endocervical adenocarcinoma that was found quite unexpectedly in an ascites fluid on a cell block. This actually wasn't present in the thin prep, but was present in the nicely concentrated cell block. So you can see really crisp, strong membranous Claudin-4 expression. Now, this also nicely demonstrates the dual stain that we had available at Brigham and Women's Hospital. This was a AE1, AE3, and WT1 dual stain. So WT1 is a nuclear marker that is expressed in mesothelial cells and cells of serous origin. So here you can see the background reactive mesothelial cells. You have some macrophages in the background that are double negative, and then you have your endocervical adenocarcinoma right here, which is negative for WT1. You can see the light blue counterstain of the nuclei is not picking up WT1. Now we have the AE1, AE3 cytoplasmic stain in red, which is a really nice demonstration of the adenocarcinoma here, which again, negative for WT1, but positive for AE1, AE3, and then our background mesothelial cells are dual positive. Here's some more examples of both the WT1, AE1, AE3 dual stain, as well as the Claudin-4 stain. Now, this is what's actually published in this paper. And when I went to write this paper, I forgot that I had taken the really beautiful image that I showed you on the last slide of the really nice, strong membranous staining of Claudin-4. So these are a little bit more of show you the spectrum of what we saw in real life practice with Claudin-4. It's a little bit more faint, a little bit patchier, but again, you're really looking for that membranous staining. So the staining, really that line between the cells. And then again, our WT1, AE1, AE3 dual stain. So on the top row, we actually have a serous neoplasm. So we have a nice papillary group here. And here's our nice dual stain. So this nicely demonstrates how those serous neoplasms are positive for WT1 and also a cytoplasmic positive for the red stain AE1, AE3. And then on the bottom, we had a poorly differentiated carcinoma that was positive for Claudin-4. And then again, we show the sort of classic non-serous carcinoma staining that we see where we have negative WT1 staining, so the nuclei are negative, and red positive AE1, AE3 staining of the cytoplasm. So we found this dual stain and the Claudin-4 stain as a really useful initial workup. And then once we had that information, we could proceed with more specific stains to characterize where the cancer came from if there wasn't a really definitive clinical history. So one question that might still remain is, can we differentiate reactive from invasive neoplastic mesothelial proliferations on cytologic features alone? And if you ask experts in this field, you're going to get a variety of responses. And I would say a lot of the people that I've talked to have said, when the clinical history and the radiographic findings are classic and your cytologic findings fit, so that would be what we call our triple test. If all of these things fit together, then we can be fairly confident about making this diagnosis, or at least suggesting this diagnosis if you don't want to go all the way there on cytology alone. But there are certainly still people who feel uncomfortable making the diagnosis of mesothelioma on cytology alone, and that is with good reason. It's a really has big consequences for the patient. They're probably going to go on to have a very invasive surgery, which certainly has a great impact for them going forward. On the other side of that coin, making an early diagnosis, if the diagnosis really is mesothelioma, may give the patient some more options as far as their treatment going forward. So the decision might be, how far do we go on cytology, or should we suggest additional tissue or a biopsy for more definitive diagnosis? The tissue biopsy is really the only place where you can see that definitive invasion. So that's really why a lot of people feel uncomfortable with the cytologic diagnosis of mesothelioma. So I'm going to tell you a little bit more about a stain that can actually help quite a bit in making this diagnosis more definitively. So we have an immunohistochemical stain that's relatively newly identified within the last few years called BAP1, and it's actually BRCA-associated protein 1. It's involved in DNA repair and transcription regulation as well. So it might not surprise you to know that something so integral to sort of cell function might cause some problem if it's mutated in the germline or all of a patient's cells. So there is actually a BAP1 tumor predisposition syndrome. It is autosomal dominant, and not surprisingly, malignant mesothelioma is one of the tumors that these patients who have a BAP1 germline mutation can get. But there's some other interesting tumors that they can get: melanomas, clear cell renal cell carcinomas, as well as basal cell carcinomas, and you can read more about that here. So in patients who don't have this tumor predisposition syndrome, but just have a sporadic mesothelioma, BAP1 is lost in a subset of mesotheliomas, but the nice thing is it's retained in reactive mesothelial proliferations. So when BAP1 is lost, we can be pretty definitive about diagnosing mesothelioma. So, but it is actually only lost in about 50% of cases. And I'm going to show you some of the pitfalls of interpreting BAP1. It's really important that we interpret the loss of BAP1 really strictly. So you have to have a background internal control to make this interpretation. So it has pretty high specificity when it is lost, but it is certainly not lost in all mesotheliomas. So if BAP1 is retained, it's kind of back to the drawing board. If you can't make a morphologic diagnosis, you're still a little bit stuck. So this is one of these morphologic kind of classic cases with supracellular effusion, but it nicely demonstrates loss of BAP1 expression. So this is a mesothelioma case where we have really cellular clusters that have a bit of appearance of that scalloped border on the cell block. And then we have the BAP1 stain here. So you can see the light blue counter stain of the nuclei here. That shows us that BAP1 is lost within the tumor cells. But what you have to look for is the background inflammatory cells. So that's what really tells you that this is for real lost in the patient cells, tumor cells, and not a problem with the stain or the fixation of the specimen or other sort of pre-analytic factors. So here we have nice nuclear staining in background inflammatory cells. So that's what tells us it's safe to interpret this as BAP1 loss, and that we can really use this as evidence for being more definitive about our diagnosis of malignant mesothelioma. A few more examples. This is one of these cases that would be very difficult for us to diagnose. So similar to one of the cases I showed you, this actually has a little bit of a rhabdoid morphology, eccentric nucleus and a large amount of cytoplasm here, but it's these dispersed individual cells. It really isn't the classic cytomorphology of mesothelioma, but certainly we were concerned about it. These cells looked a bit atypical, and the BAP1 is actually lost in these cells. So it's certainly something where you want to make sure that you have a good population of cells to evaluate when you're looking for loss, because you don't want to just be interpreting patchy staining. But again, we have our background inflammatory cells that are positive. They show that nice nuclear brown staining to show us that the stain really worked. Sometimes it can be a little bit faint, but you have to definitely look for those background cells. So this is a little bit more of a classic mesothelioma case with a papillary appearance. And then again, showing BAP1 nuclear loss here. All right, so going back to our cases. So thinking back to case one, this was the 80-year-old woman with a history of prior hysterectomy and a pelvic mass. So it turned out, at least from our records, the prior hysterectomy had been done for a benign reason. So we were sort of starting fresh with evaluating this fluid. We attempted a PAX8, which was unsuccessful due to lack of cellularity. And then it turned out she actually had a prior core. So this is the piece of history that I withheld from you guys to make it a little more educational. So this is not the typical case that we see for a high-grade serous carcinoma. We often see these patients as they're getting their staging workup, and they haven't had a prior diagnosis. But in this case, she had a core, she had a high burden of disease, and they actually wanted to do neoadjuvant treatment prior to staging and debulking her tumor. So she actually received neoadjuvant chemotherapy. And we thought that perhaps this is why it was so paucicellular. We only had these rare cells. So we still, in this context, we didn't feel that we could be definitive. We didn't have enough cellularity to sort of confirm with our immunohistochemical stains. So we did call this suspicious for carcinoma, just based on the really highly atypical appearance of these cells. And then we did comment that the paucity of diagnostic cells might be due to a treatment effect. So it's possible if you saw a washing of this patient when she first presented prior to chemotherapy, that she would have had a positive fluid. Next, going back to case 2, and just to refresh your memory, we had some of these sheets of cells that had relatively bland nuclei, but then some of them had at least the appearance of a higher nucleus to cytoplasm ratio. And then in our cell block, we had these other cells that had a little bit more rhabdoid appearance and really caught our eye. But then other cells in the background that had a really classic appearance of strips of mesothelial cells. So here we see our immunohistochemical stains. So the 2 stains that I did in this case were calretinin and WT1. And calretinin is a nuclear and cytoplasmic stain, and we did see some of these large sort of rhabdoid appearing cells that were positive for calretinin, although they are somewhat rare. The sort of frustrating thing about some of these stains is that they don't always work the way we would like. And here we see a little bit of patchy calretinin staining. This can sometimes be due to factors intrinsic to the specimen. We don't always know why these stains don't work out the way that we would like, and that's why I always like to do a panel. So you aren't hanging your hat on only one immunohistochemical stain. So here we have WT1 highlighting some of these a little bit more reactive, slightly more rounded looking single cells. And then also nicely showing nuclear staining in those strips of sort of definitive benign mesothelial cells in the background. So we felt confident calling this negative for malignancy. I was actually able to compare this case with the surgical specimen, and that showed mesothelial hyperplasia that had a very similar appearance to these slightly revved up cells with a little bit more cytoplasm. And she did have actually an interesting endocervical adenocarcinoma that involved the ovary. And it looked nothing like any of the findings that we saw in either the thin prep or the cell block. And that endocervical adenocarcinoma was strongly P16 positive. So you might wonder, could you use P16 to evaluate, are these coming from the endocervical adenocarcinoma? It turns out P16 can be positive in some mesothelial cells as well. So I didn't pursue that any further. Next, moving on to case 3, this was our woman with the history of breast adenocarcinoma. And we had these thicker clusters of cells that had some prominent nucleoli and some concerning features, and then rare clusters in the cell block that were giving us mixed messages with some of this hint of windowing, but then a little hint of a red nucleolus in there. Definitely some nuclear enlargement in those cells. So this is a case where stains really helped a lot. Even though the cell block was fairly paucicellular, I was glad that I attempted these stains. So again, here's the H&E. So I did calretinin, which is shown here. We found some clusters that were really definitively calretinin negative. They don't have calretinin in either the nucleus or the cytoplasm. And then I was able to try 2 breast markers. So instead of using estrogen receptor as a diagnostic marker, we like to use these markers for breast origin, which are GATA3 and mammoglobin. both of these come with their own caveats that they can be expressed in other tumor types. But in the right clinical context and particularly used together as a panel, these can be helpful. So GATA3 is a transcription factor, so this is a nuclear stain. So we see nice nuclear positivity with GATA3, and then mammoglobin is a cytoplasmic stain. It was really rare cells for mammoglobin, but they were starting to cluster up a little bit like this, which made us feel more confident that this was real. So even with rare cells in the cell block, we were able to call this positive, consistent with metastatic breast carcinoma in this pleural fluid. Next is case 4. This was our 66-year-old woman with a history of non-small cell lung carcinoma. And she had the right pleural effusion now and also a concurrent PET positive lymph node. So we were actually able to compare with the concurrent lymph node, which was quite cellular and had really nice morphology. So here we have our concurrent FNA, both the Diff-Quick stain and the Papa-Nicolau stain. So here you can see some of these nuclei with prominent nucleoli, very large irregular nuclei. And so that's kind of what we can compare our cell block to. Again, looking back at our cell block, it was these really rare atypical cells. And we were very dubious about whether this would really be enough to stain, but we tried it anyway. So we did TTF1, which is a stain for lung as well as thyroid origin. So again, another one of those you have to take in the clinical context. It's a nuclear stain. It is a transcription factor, so you're looking for that brown nuclear staining. And we had rare cells that were TTF1 positive, but like this one, some of them were fairly atypical. So we felt pretty confident that we had a good correlation between the morphology and the immunohistochemical stains to make the diagnosis in this case. So our final diagnosis is positive for adenocarcinoma, and again, noting the TTF1 positivity, and we like to note in our comment that we did compare to the patient's other specimen. So some additional considerations for your workup. So just summarizing some of the things that we've talked about that don't necessarily fit into this nice idealized flowchart. So you definitely want to correlate with the clinical and imaging findings. These can really help you narrow down your differential diagnosis and think of diagnoses that might not initially occur to you looking at the morphology, but things that might be really important for the patient to rule out. So here at UW, I like to do stains for mesothelial origin as sort of my initial workup when I'm thinking maybe these might just be reactive mesothelial cells, or even potentially mesothelioma rather than an adenocarcinoma. And then I like to do kind of a panel when I'm really sort of on the fence and I say there's a good chance this could be adenocarcinoma, but again, I'm not really sure could these be reactive mesothelial cells. So I like to target my adenocarcinoma stains based on the clinical presentation and some sort of basic factors like the patient's sex, the history, and the specimen site. So some things to just keep in mind for men, you don't want to forget the possibility of a prostate cancer. And then for women, again, serous or Müllerian origin is kind of the wild card that can pick up WT1, so can confuse the picture with our mesothelial stains. And then some of you might be familiar with using cytokeratins as an initial workup in other sites. We like to use CK7 and 20 to kind of localize the source of cancer. Is it coming from the upper GI or the lower GI, lung or breast? So these can kind of be useful as an initial workup, for example, if you have metastatic adenocarcinoma in a lymph node, but they can be a little bit more confusing if you have the potential for mesothelial cells in the background in these effusions, particularly CK7 can be positive in mesothelial cells. So I would really recommend using these only if you have a clear non-mesothelial population, and then you can kind of go down that differential diagnosis. So I wanted to mention some of the emerging technologies in this field. So there are some challenges that make serous fluids sort of a good target for new technologies. So sometimes we have rare cells, and we'd like to test those rare cells for multiple parameters. So we're doing multiple stains on one cell block, but each time we cut deeper into that cell block, we're hoping we still have enough cells left to do our stains. So if we could do multiple tests on an individual cell, that would be really helpful. So the opportunities here are that our fluids are minimally invasive. They often have to be collected for therapeutic reasons, and then specimen volumes can be high, even though sometimes these specimens are paucicellular. So you could have the potential to take a very large volume and concentrate that down to get the cells that you need. So one thing that's out there is circulating tumor cell technology. So this we classically think of in the context of blood. So this is one of these technologies where we refer to as liquid biopsy. And often pathologists and maybe even cytotechnologists who are, if we're in the know, we might feel a little nervous about this idea of a liquid biopsy. We might be worried that this is going to replace a true biopsy or a fine needle aspiration, that patients might be able to get their diagnosis from only a blood specimen. Certainly that is something that is not currently realistic in a sort of a general application, but this is something that is more used in the context of clinical trials. But what's great about circulating tumor cell technology is it takes very rare cells out of the blood and actually can test them from multiple parameters. So you can imagine the same technology could isolate rare cells from a fluid. And again, test them for multiple parameters. So, and here we're really talking about the enrichment phase of circulating tumor cells. So a lot of what I know about circulating tumor cells, I learned from Ali Lowe, who is the director of the circulating tumor cell lab at Brigham and Women's Hospital. And one thing to note, if you feel a little anxious about liquid biopsy, circulating tumor cells can actually be analyzed within the cytology lab. So because there is a morphologic component to this assessment, it's a great place for cytotechnologists to get involved. And that's what they were doing at Brigham and Women's Hospital. So, sorry, my cropping got a little bit messed up here. So this is actually to show you the different channels. So the image that was supposed to be showing here is probably cut off at the top, but the idea I can still tell you about. So when we're looking at circulating tumor cell samples, we have multiple fluorescent channels, and we actually use magnetic beads bound to an antibody to isolate the cells, and then we use these fluorescently labeled antibodies to stain the cells. And we use a cytokeratin, which is going to stain the cytoplasm of circulating tumor cells or cells of epithelial origin. And then we use DAPI, which is a nice nuclear fluorescent stain. So what's supposed to be shown here is the cytokeratin stain is really staining the cytoplasm, and then the DAPI stain would be in the center, the nucleus. So when you look at the composite image, this would be a green cytoplasm and then sort of this magenta center for a nice morphology of a circulating tumor cell. The cells that you're seeing here are some of this is actually an example of a very degenerated circulating tumor cell, and then some other cell types. So actually we can see inflammatory cells that come up on the DAPI stain, but they won't come up on the cytokeratin stain. So this is a really nice way to do multi-parameter analysis on a cell, on very rare cells in different specimen types from blood or other fluids. So here's Ali Lowe, and this is a really nice study that she did, which just sort of takes home the idea that circulating tumor cell technology could nicely mesh with conventional cytologic techniques. So she actually took samples and processed them for circulating tumor cell analysis. And then after that processing, sort of fed them back into a cytologic preparation. So we could see what they look like after that processing. So here's the original sample. We have a diff-quick stain and a Papa-Nicolau stain here. And you can see there's this little brown haze over the cells, and that's actually those magnetic beads that are bound to the antibody that captures these as circulating tumor cells. So there are actually a lot of opportunities for downstream analysis, and the morphology component of this could really nicely integrate with the cytology lab. So could we use these for body fluid specimens? Here's another technology that I found that's sort of been published back in 2017. They used a microchip and sort of multi-parameter analysis again to label individual cells in these microwells. And then what's really cool about this is once they had these individual cells isolated, identified them as circulating tumor cells based on the appropriate labeling, they were actually able to retrieve single cells and then process them for molecular testing after that. So they were looking at EGFR mutations and KRAS mutations, which would be relevant in lung cancer as well as others. So they actually looked at pleural fluids in this study in addition to blood specimens. So this is something that's definitely not in clinical use yet, but could be really useful as a potential adjunct to our traditional cytology techniques. This is just sort of to remind us that these rare cells really do make a big difference in our cytologic specimens, as all of us know. And if we could sort of probe these individual cells for more parameters, we might be able to give a more definitive diagnosis for our patients. Then I just wanted to give a brief shout out about the International System for Reporting Serous Fluid Cytology. So this is something new that's on the horizon. It's going to be a new book that's going to be coming out soon. So this is a joint venture by the International Academy of Cytology and the American Society of Cytopathology. And there are some really great sort of long-range goals of this project. And I think if we standardize our terminology in serous fluids, we'll really bring our serous fluid diagnoses into the realm where we are already with cervical cytology, as well as thyroid, where we can really facilitate sharing information and transfer of patients to different hospitals, making sure we're all speaking the same language. So goals are standardization, as well as estimating the risk of malignancy for the diagnostic categories, as well as facilitating data sharing, both in a direct clinical setting as well as a future research setting. So here are the diagnostic categories. You'll see that these are very similar to probably what you already use. So I don't anticipate that this is going to make huge waves in sort of your day-to-day practice, but will be a nice way to standardize. All right, so here are my references, and I just wanted to thank you all for listening. I think Josh is going to start taking some questions if there are some from the audience in the chat box. And I just wanted to make a brief plug at the end for our cytotechnology program. So I'm the faculty director for the cytotechnology program, and I know I'm preaching to the choir here, but as you know, cytotechnology is a wonderful career, and we actually have multiple positions available for the 2019-2020 academic year, and we are recruiting for beyond that as well. We're currently accepting applications, and good news, only a bachelor's degree is strictly required. We love to see people with a biology background, but if you have colleagues, friends, or family who might be interested, please send them our way. We'd love to hear from them. So, all right, thanks again, and thank you so much for having me.
All right, well, we don't have any questions in the question box, but I did have one that I'd like to bring up, and we can open it up to the audience that's here right now. In regards to blood tumors that you're able to find with the technology that looks strictly at blood, is that limited to just so cancers that have breached a membrane, like a primary squamous in the lung may not necessarily circulate, correct?
So that's a really great concept. And I think what's interesting about circulating tumor cells is that if you take asymptomatic patients and do a collection for circulating tumor cells. So it's actually a little bit of a larger volume blood collection in order to get enough blood to isolate these. Asymptomatic patients, no known history of cancer, you can find cells that meet the criteria for circulating tumor cells. When there's no known cancer diagnosis, we like to call those circulating epithelial cells because we don't really know what the significance of those is. You know, are these just benign cells that kind of got displaced and they're sort of floating around? They're not necessarily malignant. They're not necessarily going to set up shop somewhere to sort of metastasize, or are these occult cancers that just haven't been detected yet? But yeah, you would think that sort of from a physiologic perspective, these tumors would need to breach the sort of basement membrane and sort of reach the circulation in some way. They would have to in some way be spreading hematogenously. The cases where we see these most commonly would be breast, actually breast carcinoma. These techniques are FDA approved for enumeration, predicts, sort of counting how many circulating tumor cells are there can predict prognosis for breast cancer patients, although it's not very commonly used. And then colorectal cancer, prostate cancer, and lung are kind of the most common ones where we see. But I'm not sure adenocarcinoma versus squamous cell carcinoma, if one is more common than the other to see in circulating tumor cells.
Great, thank you. Are there any other questions from the present audience? I'm still not seeing anything on the webinar end. Looks like the answer is no. All right, well, thank you very much, Kaitlin. We'll have to start our transition into the next talk. Just give us one moment and we'll start setting up. Thanks. All right, so we're back, ready to get through the WSC announcements and business meeting. Before I proceed, I would just like to give a little bit more time to our industry supporters, the Wisconsin State Laboratory of Hygiene, for helping us set up all of this equipment. And I was listening on the audience end on my laptop, and the audio sounds really crisp and the visuals are great. There were some either PowerPoint or webinar issues regarding Kaitlin's talk, but I believe that we will be able to forward the actual PowerPoints to everybody. So it was just a few citations that were cut off, which I'm sure is fine for the live, but some people might want to go back and look at those papers. So, and Kaitlin also had an entire page dedicated to that, so that'll be there for you. But thanks again to the Wisconsin State Laboratory of Hygiene, Jim Hermanson, for getting this going for us. Thanks again to Roche. If you're in the Wisconsin and Southern Wisconsin area, Anna Callender is a great representative and does really great work. Our friends at Newcomer Supply, who have been, they're brand new, kind of on the scene, and they've been very generous with us from the beginning. Sakura, if you are looking into cytological or histological processing, I can personally vouch for a lot of their products. If you ever have any questions, you can email Angela, or if you want personal pointers on their stuff, you can talk to me specifically. Just email WSC. Our emails that are posted on the website. And then special thank you to Hologic, and we'll get to a little bit more of their stuff. They are our platinum supporter for this event. So we can begin with the WSC business meeting. This meeting is a little bit different, where we had voting in advance of, and technically you are still allowed to vote until the end of the business meeting. All of our elections ended in landslides, so I kind of doubt that anything will change. But anyway, here are the various reports for those board members who submitted them to me before the meeting. From membership, we have 62 current members, 48 paid, 11 honorary, with 3 students this year. For this webinar, we have 25 paid attendees, 24 members, and 1 non-member. With an additional 3 students, 2 speakers, and some WSLH staff who are attending. So I mean, I think that's really great that we're maintaining membership, and the great part about this particular meeting, even though we don't get to see each other in person, at least 5 of the folks who signed up were from out of state. Is that correct? I think about 4 or 5 different states, including Wisconsin. So at least 4, I would say, which is great that we're pulling folks from around the Midwest. I think that this might be a venue in the future to have a multi-state meeting or a multi-state talk, something like that. The treasury report for this year, bank account as of last statement on the 9th of April was $7,058.37. The balance as of the 1st of May was $76.28.37. Spring meeting revenue expenses. Now there will be some changes, I believe, during the after meeting, but as of shortly before the meeting, our total revenue was $1,209.70 with vendor donations and registrations. I don't know if that includes membership registrations. Yes, it does include membership registrations. Expected expenses anywhere from $0 to $200, thanks to the WSLH. The other advantage of doing a meeting like this every so often is that we don't have to deal with hotels and caterers and all of the other little things or big things that go into putting a meeting together. So I think that this will be a hit, and it'll allow us in the future to have discounted fees for our membership when we do in-person meetings. And thanks again, especially to our industry partners who really make this possible. It's going to be, I think, an exciting new way to spread information to our membership. The secretary report, no edits to the minutes in the previous newsletter, and I assume this will be voted in when we have a quorum, which I think we do today. President, nothing to report. Vice President, Tracy would just like to make a extra special thank you to our industry partners with over $1,600 of total support as of, I believe that was Friday that you told me. And an extra special thanks to Katie Hughes, who is our Southern Wisconsin Hologic representative. She has been instrumental in getting vendor support from Hologic, and just she's been involved with the society for quite a long time. We just like to send some thanks to her, and just thanks to all of the vendors and supporters, past and present. They really do make these meetings feasible. They reduce the cost for membership. They make it easier because, you know, who wants to spend Saturday, you know, out in the middle of nowhere if it's going to cost you $120. I know I do, but not for everybody. Scholarship director has nothing to report. Newsletter editor has nothing to report, and your webmaster also has nothing to report. I can open it up to the floor if there is any last minute announcements, but I'm seeing a lot of nods in the no direction, which is fine. So assuming that there isn't a dearth of voting in the next 28 minutes or so, our new officers, our likely officers, I should say, this is technically our business meeting, but at the end of this, we will go back and count the votes and make any announcements via email. But assuming that that doesn't happen, our secretary will remain to be Leah Schultz. Vice President Sally Sneedsy, am I butchering that? But she's not here yet. Our newsletter editor will change over to Stephen Berger. Thank you very much for volunteering for that. And our webmaster will remain me, Joshua Falks. And I'd like to take a moment to thank Colleen Stowe for her tenure as president for the WSC. She did a fantastic job putting together our 50th anniversary party / meeting. I see a lot of folks who were there, and I remember it being an exceptional get together and celebration of this board and all the things that we do. And I just like to take a moment to thank Colleen for all of the work that she's done. And she's not gone, she can't get rid of us. She will continue on for another year as past president, and maybe we can talk her into another seat down the line. So having said that, our new president, who is with us today, Angie Watruba, who has been a colleague of mine for at least a couple of years. So if you haven't met her, here's a little bit of a background and maybe hints as to what's coming for our society. She is a graduate of the Marshfield Cytotechnology program, currently a cytotechnologist at UW Health in Madison. She's been there since 2007 and served as a bench tech, FNA liaison, quality senior, LIS analyst. She is certified in Beaker AP, of which I'm very jealous. I'm not looking forward to the possibility of having to go through that process. And currently the manager of the cytology area at UW Hospital. Her first role with the WSC was in 2008 as scholarship director. She served 3 terms. That was before my time, so thank you for that. She loves camping in Wisconsin state parks, kayaking, and making crafts. And I know that she's also a fantastic photographer. So, so thank you for signing up, and we look forward to what's happening in the future. So one more thing regarding industry support. Hologic has supported us, I think, at least for the past 3, if not more, meetings at the platinum level. So I need to do a couple of plugs for them. I don't know if you all remember when the USPSTF guidelines came out during the public comment phase. Hologic was instrumental in helping us with the write-in to keep co-testing in the spotlight as a possible screening test. And so I think in part due to their advocacy, that actually went through and is part of the USPSTF recommendations that are in place right now. Additionally, I would like to plug for the Genius video that they have out. If you go to Hologic's website, they did a short film on the importance of co-testing and kind of highlighting the importance of doing these 2 screening tests in conjunction, how people can fall through the cracks if it's not done in certain cases, especially in women over 30. It's called Amy's Story. So if you have a spare, I believe, 6 or 7 minutes, you can go to Hologic's website and watch that video. And I would encourage, if you are as touched by it as I was, to share it with your friends. You know, especially the younger generation, that would be most helpful. So that brings us to the end of our business meeting, unless anybody has anything to add. I think we have a quorum, so should we vote to close? Is that what we do? I wish Charmaine was here. Tracy motions to accept, I second. The ayes have it. Motion passed. So without further ado, we have John Shalkham, who is going to give us a talk on salivary gland cytopathology and the Milan system. And John is currently an assistant professor at the University of Wisconsin in the cytology program, and he is currently emeritus status. Yeah, so we're very lucky to have him in the area and getting him to agree to do crazy things like this. So thank you very much, John.
Thank you, everyone. I think it's fascinating to come back here and do these kinds of presentations. I want to thank all of you at the WSC for inviting me to do this, but I especially want to thank all you who are attending. It's a beautiful sunny day on a Saturday. There's many things you'd probably rather be doing than sitting here and listening to presentations. But I think it's a reflection of professionalism for those people who do take their time out to try to learn a little bit new, make sure their skills are as current as possible. And I thank you all for doing that. That's a really great reflection on your professionalism by doing that. Now, one question technologically, I advance this by hitting what key? You can see I'm somewhat of a Luddite in my technology here. So, oh, I can use this. Okay. All right. There's one good thing about now all these new technologies. You can't use a laser pointer on anything, which is really just, you know, we had these beautiful laser pointers put into these things, and now you can't do it anymore. Okay. I really want to stress, for those of you who are interested in learning about salivary gland cytopathology, to go to this website. I have used many of their photos in my presentation here, because some of the things that we're going to talk about today are going to be new concepts to you in reporting. I want to acknowledge I am probably not going to finish this presentation. I put it all together so that you can go back and look at all the malignancies and things like that that you probably are more familiar with in some of the new reporting categories. It's all there. It will be online for you to look at. But this is a 2-hour, 2.5-hour presentation if you want to really get through this with any time frame. So I wanted to go slowly. I don't want to rush through some of the new concepts with you. So I do apologize. I will not be finishing it, but it will be here for you to look at as we move along. Just a quick review of anatomy. Remember, you have salivary glands all over the place. This is a very interesting thing to remember. The largest one is your parotid gland. You have the submandibular gland and the sublingual glands. Just recognize that these different glands have different incidences of disease. Most of the diseases we're going to be talking about, parotid is by far the most common site, but recognize we can have multiple sites, and some sites have a more frequent occurrence of certain kinds of tumors. So we're not going to go through that at this time, just for time-saving process. Parotid is located near your ear. It's encapsulated as a pure serous gland secretion, drained through the Stenson's duct. For those of us who like developmental anatomy, it's ectodermal in origin, and it has associated lymph nodes. So in aspirating a parotid gland, you can see lymphoid material sometimes. Submandibular gland is beneath the jaw. It's more serous and mucinous, so it does have both kinds of cell types. It's about 1/3 to 1/2 the size of the parotid, and it's ectodermal in origin as well. And the sublingual gland is located behind the tongue. It's more mucinous than serous, so we can see more mucinous cells in a sublingual aspiration. It's quite small. It's about 1/10 the size of the parotid. It's both endodermal and ectodermal in origin. I'm not going to get into all the various ducts. Okay, normal cells. What are you going to see in a salivary gland? You can see cells like the myoepithelial cells. You can see ductal cells. You can see acidic cells, can be either serous, mucinous, or oncocytic. And there's other kinds of cells such as adipose, lymphoid tissue, metaplastic cells, and respiratory epithelium, depending on how the aspiration was performed. So these are the run through very quickly of the normal cell populations that you would encounter in a salivary gland aspiration. Here's a quick picture of the myoepithelial cells. They're flat cells around the ducts and acini. The cells have oval or spindle shaped. They're about the size of a lymphocyte, and the nuclei can be on different planes of focus when you're looking at them. So photography does them no justice. Two-dimensional photography in a three-dimensional image doesn't work really well. But you've all seen myoepithelial cells. They're small football-shaped little cells. The ductal cells are cuboidal or columnar in shape, depending on the diameter of the duct. You can see them in cluster sheets or in honeycomb pattern. Nuclei are usually oval or some maybe a little bit elongate. Cells have somewhat scant cytoplasm, and the nuclei are regular round with bland chromatin. Acinic cells are large cuboidal or pyramidal cells, round, uniform, eccentrically placed nuclei with granular cytoplasm. They may have small nucleoli. That's basically what they look like. Oncocytes, everybody's favorites. Everyone likes oncocytes. They all look so pretty. They're cells with well-defined borders, abundant granular cytoplasm. I usually ask what those granules are, but I won't because I don't want to embarrass folks. And they have large round nuclei with prominent nucleoli. Okay, other cells we mentioned before. Here is a book you should have in your laboratory if you do any non-gynecologic cytopathology. This Milan system is a very good book to have in your laboratory, if not in your personal library. It is very intense. There's a lot of really great information in this book. I strongly recommend that if you have any experience or opportunity to do salivary gland aspirations, you need to implement this reporting system. I don't know how fast it will be implemented to everyone, but I do think it's a really good system The book is really a great thing to have in your library. I really recommend it. So, I don't own any stock in the company that's selling the book. So, no ownership here whatsoever. But a quick summary of the Milan system includes these diagnostic categories. About 25% of the rate of malignancy is what ROM stands for. So non-diagnostic category, you still can have some malignant process. If it's non-neoplastic, it's much lower. Atypia of undetermined significance, a new category we'll spend some time talking about. Neoplasms, they can be benign, and they can also be malignant. Neoplasms, uncertain malignant potential, SUMP. You'll love SUMP as well. Then there's suspicious and malignancy. Notice how as you progress through the categories, the rate of malignancy increases. And that's what this categorization is supposed to be about. It's supposed to be able to provide that kind of information to the clinician, what the chances of malignancy will be. And as you become more proficient in salivary gland aspiration cytology, in theory, I think you can even improve on these numbers. So let's talk about the non-diagnostic category. A salivary gland aspirate, one that is qualitative or quantitatively reasons provide insufficient diagnostic material to provide information. Generally, it's less than 60 lesional cells or a poorly prepared, poorly preserved, poorly stained sample. Not that we ever see those, but they do happen. And non-neoplastic normal salivary gland elements in the setting of a clinical or radiologically defined mass. Looks like clinically or radiologically it should be something, and all you get is normal material. That would be non-diagnostic. Non-neoplastic, on the other hand, is used for specimens that show benign, non-neoplastic changes, including such associated with acute or chronic reparative response to inflammation, structural alterations and infection. Designation of non-neoplastic is intended to be used in conjunction with the available clinical and radiologic information. This whole Milan system stresses clinical, radiologic, and cytologic findings. That collaboration with the clinical findings and what you find in radiologically is stressed repeatedly, as is adjunct testing. We do not have time to get into the adjunct testing here. I wish we did. And now we're into a 4-hour presentation and the sun is shining. I'll never keep you that long. So atypia of undetermined significance applies to salivary gland FNA that lack either qualitative or quantitative cytomorphologic features to be diagnosed with confidence as non-neoplastic or neoplastic. In addition, the FNA exhibits atypical cytomorphologic features that excludes the possibility of classifying it as non-diagnostic. Most samples will represent reactive atypia or poorly sampled neoplasms. So this is, again, I don't know. It could be, it could not be. There's going to be a percentage of these cases. Neoplasms that are benign. These are FNA features showing characteristic features of benign epithelial or mesenchymal neoplasia of the salivary gland. Most common, pleomorphic adenoma or Warthin tumors. We all know those. Those are the ones you know. Neoplasm, salivary gland neoplasm of uncertain malignant potential. This will be a brow through. Deep breath here, John. Uncertain malignancy is diagnostic category reserved for FNA samples that are diagnostic of a neoplasm. However, a definitive diagnosis of a specific entity cannot be made. This diagnosis should be used in cases in which the malignant neoplasm cannot be excluded. The majority of these cases will include cellular benign neoplasms, neoplasms with monomorphic lesional cells, basaloid neoplasm, oncocytic or oncocytoid neoplasms, neoplasms with clear cell features, neoplasms with atypical features, and low-grade carcinomas. Wow. See why we're not going to get to malignancy? Okay, suspicious for malignancy is classified when some but not all of the criteria for specific diagnoses of malignancy are present. and yet the overall cytologic features are suggestive of malignancy. This is consistent with most of the other types of non-gynecologic or FNA samples we look at. There's always going to be this suspicious category that just does not have all the criteria you need to give an unequivocal malignant diagnosis. And lastly is malignant. Combination of morphologic features that either alone or in combination with ancillary studies is diagnostic of malignancy. When possible, an attempt should be made to provide the grade of the neoplasm as well as the specific tumor type. So a lot of things we need to do with the malignant process. Okay, had to run through those. Those are the classifications in the textbook. I think it's important that's why the book is so important to have as part of your library. So non-diagnostic, as we mentioned, is less than 60 lesional cells. Air drying, obscuring blood, poor staining are all some of the features that we can encounter that can lead to a non-diagnostic category. We've talked about all these before. Non-mucinous cysts could be a good example. You see a lot of fluid, very few epithelial cells. Some of these examples of non-diagnostic include presence of only benign salivary tissue, poor staining, and we've mentioned all these. Here's an example. We had this on an FNA sample. This is from the Milan website. What would you say about that? Well, there's an artifact present, isn't there? But there's no lesional cells. So non-diagnostic. Here again, we have some debris with skeletal muscle cells, and some few inflammatory cells. Again, non-diagnostic. Cyst fluids, non-mucinous cysts. Mucinous cysts come into a different classification. Here we can see non-mucinous cysts with some histiocytes and debris. Okay? Non-neoplastic can include many categories. Salilithiasis, acute salliadenitis, salliadenosis, granulomatous salliadenitis, reactive lymph node hyperplasia, benign lymphoepithelial lesions, lymphoepithelial salliadenitis, salliadenosis, and oncocytosis. Lots of things. I'm going to go through these quickly. I'll try to make sure we cover everything, but there's a boatload of information here. So lithiasis, a stone basically, occurs primarily in the submandibular gland. About 80% of them occur there. The parotid gland, about 20% of the cases there. So what you ultimately see is a hypocellular aspirate with scant or absent acinar cells, some benign ductal cells, and calcification. We can see some calcification here, some stone-like material on the right, and we can see some obstruction of the duct followed by some inflammatory cells as well. Acute salliadenitis, we're going to see acute inflammatory cells, maybe with or without bacteria. You may see some later stages, you might see some look like some granulomatous type of changes as well. But the degenerate acinar cells and our scant number of ductal cells may be seen. Excuse me, here's an example of acute salliadenitis. You can see the inflammatory cells. If we were doing a gram stain on this, we would see some pyogenic bacteria, staph, strep, sometimes viral infections like mumps can cause this as well. On cytology, this looks a lot like an abscess from other sites. Chronic salliadenitis, you oftentimes see hypocellular smear with plasma cells and lymphocytes. Again, rare epithelial cells. You may see occasional stromal fragments. So this can be a very painful aspiration. So clinically, if you're out doing the FNA, the patient may have a lot of discomfort. So submandibular gland is the most common site of this as well. The granulomatous salliadenitis, basically cytologic features include hypocellular. You can see some epithelioid histiocytes, lymphocytes, neutrophils, multinucleated histiocytes, stromal cells with a necrotic background. Here we can see some the spindle-shaped epithelioid histiocytes. You can see these present on some of these cases. Okay, the benign lymphoepithelial lesions, lymphoepithelial salliadenitis. Sjogren's syndrome is one that's most commonly seen. It's usually autoimmune and it's an origin of these things. Patients with Sjogren's syndrome, they'll have about a 50%, patients with Sjogren's syndrome have lymphoepithelial ciliadenitis in about 50% of the cases. These patients also will have a higher risk of having lymphomas in the future. So here's some of the features we're going to see. We're going to see cohesive ductal cells, squamous epithelial cells, metaplastic cells. You can see a dense mixed population of lymphocytes, plasma cells, dendritic cells, tingible body macrophages, and mostly small lymphocytes. You can see germinal center fragments. Boy, I'm drawing some minds from back way in the dark ages. I heard you, now you've heard of these things, I'm sure. Lymphoepithelial aggregates and very scant acinar cells. Here's a fairly good example of this. You see a lot of lymphoid tissue admixed in this process. Here again, we can see some here lymphoglandular bodies in the background, so we can begin to see those as well. Ciliadenosis is a non-neoplastic, non-inflammatory condition, often associated with malnutrition and alcoholism, often bilateral, again, a painful aspiration. You can see hypertrophy of the acidic cells. You may see some fat infiltration as well, most commonly seen in the parotid. Some of the features include enlarged acinar cells, normal architecture, some free nuclei, and fibroadipose tissue. Here we can see some very enlarged acinar cells. Okay, sorry for going so quickly, but I'm going to try to get done with at least as much of this as I possibly can. Josh has given me a thumbs up. I must be doing okay. Okay, oncocytosis seen in older patients. I love older adults. If you're older, you've got to be an adult. You can't be an older child. Never mind. Okay, hyperplastic changes in oncocytic metaplasia. Difficult to differentiate from oncocytoma, which is a neoplasm, so sometimes this can be a bit of a challenge. Generally see acinar cells and ductal cells with abundant granular eosinophilic cytoplasm, normal cytoarchitecture, variable amounts of benign ductal cells and fibroadipose tissue. Here we can see a case of oncocytosis with some pretty classic oncocytic cells. Okay. All right, I ran through this quickly because I want to spend some time on atypia of undetermined significance, a new category for most of us. It will potentially reduce the number of false negative diagnoses using this category. Its diagnostic category cannot entirely exclude a neoplasm. This category is very heterogeneous. There's lots of things involved with it. The majority of cases will be reactive atypical or poorly sampled neoplasms. Specimens are often compromised by factors and should be used rarely. Less than 10% or so of salivary gland FNAs should be falling into this category. You can see where this could easily become a catch-all for everything. I'm not sure, let's call everything atypia. And the recommendation is if you're doing 50% of your salivary glands in this diagnosis, you're probably not using it appropriately. Okay, so some of the things that we can begin to look at, reactive stuff, we can talk about reactive cases. Some of these inflammatory conditions can have reactive atypia with them. Squamous oncocytic or metaplastic changes that can be similar to neoplasms. Low cellularity specimens, but they look like they've got abnormal cells. That can be quite a problem. Basaloid cells raises the question whether it's benign or a basaloid neoplasm. Cases of chronic ciliadenitis and chronic inflammatory cells with small cohesive groups of ductal cells can be a problem. Specimens with preparation artifact also can create a problem. Okay, so morphologically, what are we looking at? We're going to see mucinous cells. Refer to saliocysts. Some of those will fall into this category. Most cysts are due to cellulolithiasis. 1/3 of cystic lesions are neoplastic. So just because it's a cystic lesion does not mean it's benign. They can be neoplastic. Extracellular mucin falls into this category because mucin in a salivary gland can be a problem. So we have to recognize that. And these cells may contain scattered inflammatory, or samples may contain scattered inflammatory cells, as well as columnar squamous or mucinous secreting cells. So here's a list of some of the various entities that can result in having atypia of undetermined significance. They're too numerous to list at this stage. You can read them, but there's a lot of things here that can fall into this category. Mucinous, if we mentioned that, tumors that can also involve cystic things like Wharton tumor, mucoepidermoid carcinoma, and actinic cell carcinoma can all have cystic components. And salivary gland lymph nodes or lymphoid lesions that are indefinite for a lymphoproliferative disorder can fall into this category as well. What would you do with a cell like that? This is again from the website. But that's maybe one or two of them on the whole preparation. Shakes you up a bit, doesn't it? I don't want to call this negative. In the past, we really did not have a good category to classify these kinds of aspirates. This would be an example of where atypia comes into a really valuable commodity. There's a lot of other things you could do, ancillary testing and like would be taking place here. But a cell like this in rare or few numbers on an aspirate from the salivary gland would be a real problem. You wouldn't want to call it negative. You wouldn't want to call it indeterminate. Do you want to call it suspicious? Maybe, but you really have some problems with this whole process. This is where atypia comes into play. Now, again, we talked about here, we can just see some mucin on an aspiration. Yeah, it probably wouldn't be bad to have water up here as I frog away. I do apologize for my voice. It is one thing about Madison at this time of the year, the pollen count is beyond any measurable. So those of us with some allergies end up sounding like this for about 2 weeks. Missy spills a little there. Okay, so you see a lot of mucin. You've got to be concerned about what you're looking at here. So recognize that this is where the atypia category comes into play. So any question? Well, no, we'll talk questions later. Please let me know, Josh, if we get any questions as we move along here. Okay, benign neoplasms. Most salivary gland neoplasms occur in the parotid. Up to 80% of them are parotid tumors. In adult, pleomorphic adenomas account for about 50% of these neoplasms. So if you play poker, you have a salivary gland aspiration. It's from the parotid. It's okay. It's pleomorphic adenoma. Why bother looking at it, right? Doesn't work too well. But that's how some people think about this. In fact, when I do salivary gland aspirations, I sometimes think about it as I'm looking for a pleomorphic adenoma until proven otherwise, because that's the most common finding we have. Wharton tumor is the second most common benign neoplasm. Mucoepidermoid carcinoma is the most common malignancy. So most common salivary gland neoplasms, I said, in the parotid. It's in advance. There we go. Pleomorphic adenoma has also been called in the past the benign mixed tumors. It's a benign process. It constitutes 2/3 of parotid tumors, about a large number of salivary gland tumors in general. It affects predominantly middle-aged patients, with women slightly more affected than men. Clinically appears as a firm, painless mass. It's very slow glowing and a solid tumor. Pleomorphic adenoma has certain cytologic features, and they're characterized by the presence of epithelial cells, myoepithelial cells, together with chondromyxoid stroma. So you have to look for that wonderful viewpoint of seeing the epithelial cells, myoepithelial cells, and stroma. This is where Romanowski stain becomes so vital. You can see the myxoid stroma on Papanicolaou stain. It's a little difficult to really classify. Give me a good Romanowski stain, and it jumps out at you, that beautiful magenta. So ductal cells appear in sheets or cohesive cells. Nuclei are usually uniform with hyperchromatic with occasional micronucleolus. Chromatin patterns are even. You see cords of uniform epithelial cells. Sometimes you see honeycomb groupings. You see spindled stroma, chondromyxoid matrix. Myoepithelial cells, as you know, are ovoid to plasmacytoid in appearance. And here we've got a Romanowski stain that tells me I'm seeing that matrix. We can also see occasionally some epithelial cells located here. I don't see any really clear evidence of stromal cells. Here we can see some more polymorphic adenoma. I see more epithelial cells. I see some myoepithelial cells in this particular image, so we can begin to see those as well. Here again, we can see some more of these very same things. The amount of matrix can vary. Sometimes you only see a small amount of matrix. So, but basement membrane material is really important to be seen. The stromal component here we can see on a Papanicolaou stain. You can see variable amounts of collagenous, myxoid, chondroid, or osteoid type of stromal components. And you can see spindle-shaped myoepithelial cells seen with this stroma. So these are various stromal components that you can see in a pleomorphic adenoma. Okay, Warthin tumor, also known as papillary cystadenoma lymphadenomatosis or an adenolymphoma. I always like the term adenolymphoma for a benign tumor. Never made any sense to me. This is considered to be an oncocytic adenoma, and about 5 to 10% of salivary gland neoplasms are Warthin tumors. Occur in about an age group between 55 and 65 with predominantly male. Tumors usually arise in the lower part of the parotid. It's often linked with smoking. Male-female ratio is 5 to 1, but that's changing as more women smoke. In fact, statistics show more women smoke than men smoke now, so 20 years from now, who knows what the mix will be. If you've ever aspirated one of these tumors, they have a very distinctive appearance of the material you've aspirated. So I think if you've ever seen one of these, you know that this material can look pretty oily, and you pretty well look at it and say this looks a little weird. So you have to take into consideration just by what the aspirate looks like that a Warthin tumor might be in consideration. Because you see this brown cystic material with mucinous material in it. Oncocytes, lymphocytes, and cyst contents can be seen. Here we can see some lymphocytes with the oncocytic changes in the back as well. So you may occasionally see macrophages and neutrophils. Here's a Romanowski stain, as you can see the oncocytes clearly with a lymphoid background. If you don't see the lymphocytes, you got to consider an oncocytoma. So that's where this presence of seeing the lymphoid material as well as the oncocytic changes is so critical. Here's an oncocytoma just for comparison. You don't see any of the lymphoid material with it. This is where you need a sharp eye, and you need to make certain you've got an adequate sample, because just oncocytes alone can be misleading. You have to make sure you have a good sample. You're not just seeing an occasional oncocyte. I like oncocytes. Okay, lipomas. You see them vary. It's an uncommon lesion, but I have actually seen one, and all you get is the adipose cell. So not much there to talk about. Schwannoma, again, a sort of a rare neural tumor, very painful to aspirate. So basically, you're going to see a lot of these spindle-shaped cells with wispy bipolar cytoplasm. Ill-defined cytoplasm. It's not very clearly defined. You can see these nuclei are small, dark, and very bland, generally speaking. You may see a small nucleolus, and you see a myxoid background. I have never personally seen one of these. This is again from the website. Lymphangioma is a rare tumor. Yeah, the cytologic features it's a hypocellular smear, occasional red cells, scattered mature lymphocytes, rare clusters of non-neoplastic salivary gland acinar cells. Never seen one. I don't have any pictures of one, but it was listed there. So hemangioma, most commonly seen in children, benign mesenchymal tumor of salivary gland, dense network of capillaries that replace the parenchyma of the parotid gland. Here's the hemangioma. You can see predominantly red cells, some spindle-shaped polygonal endothelial cells. Individual cells have oval and spindle-shaped nuclei, some scattered histiocyte. Again, the clinical history would be so critical. You don't make this diagnosis in a vacuum. You better have some clinical history that supports it. Okay. Wanted to run through those quickly again. How am I doing? Am I still okay, Josh? Again, I have a lot of material. Give me a 5-minute warning when I'm running out of time. So like I say, I'm not sure I'll get through all of this, and I'm going more quickly than I probably would like. But I want to try to get through as much of this as possible. So if there's, and still leave some time for questions. Okay, salivary gland neoplasm of uncertain malignant potential, SUMP. Diagnosis of a neoplasm, however, the diagnosis of a specific entity cannot be made. We know it's a neoplasm, but we don't know if it's benign or malignant. We can't rule out a malignant neoplasm. This could be malignant, but we don't know. The diagnosis includes the following: basaloid neoplasms, oncocytic or oncocytoid neoplasms, or cellular neoplasms with clear cell features. Again, somewhat new material for all of us, but it's important to recognize we've all studied this and done this routinely. We just haven't done it according to this classification system. So when I read this, I didn't find it to be altogether new morphologically. It just helped me reorganize in my thoughts how we were using this classification system. And I think the more I read it, the more excited I am about seeing how this classification system can be applied and used to improve the diagnostic features of salivary gland aspirations. Okay, so let's talk about basaloid neoplasms. Basically, immunocytochemistry is essential for diagnosis in these categories. You won't do this in a vacuum. You're going to need to have the immuno lab working with you very closely. These kind of categories can include everything ranging from pleomorphic adenoma, basic adenomas, basal adenomas, myoepitheliomas, basal cell adenomas and carcinomas, myoepithelial carcinomas, and adenoid cystic carcinomas. All these can fall into these categories. The stromal elements can vary as well. You can see fibrillary stroma, hyaline stroma, mixed stroma, or virtually no stroma at all. You can see cytologic features which include groups of basaloid cells with scant cytoplasm. These have high nuclear cytoplasmic ratio, which means the twitchy factor in cytotechnologists is very high. We always like high NC ratio cells. We get really excited about them. The type of stromal component is important for the diagnosis. So here is a very cellular sample that has abundance of basaloid cells. It's got some material, some stromal component material in the background as well. This would be classified as a SUMP, a basaloid neoplasm. Now, there's many things these could be, these basaloid cells. Malignancy certainly falls into a potential diagnostic classification here, but we don't know. That's why on cytologic features alone, the SUMP category is a very good one to use. So you see these basaloid features occasionally. In the past, they were always, the classification of them could be wide ranging. Sometimes they were called suspicious. Sometimes they were, even people thought them to be malignant, but you certainly didn't want to call them negative. Now we have a classification that I think helps us really identify, and it describes to the clinician the malignant potential of our diagnosis. The website has lots more pictures than I put in here, so I didn't have time for more. I would like to put a half dozen pictures in, but who has time? You don't, because I'm probably going to run out of time anyway. Malignant uncertain malignant potential, oncocytic or oncocytoid features. These are cells, these are samples that have oncocytic changes. They include things like Wharton tumor, oncocytoma, They can be seen in pleomorphic adenoma, myoepithelioma, as well as mucoepidermoid carcinoma. So they go all wide-ranging features. So what we're looking at is cellular features of neoplastic cells. They can be oncocytes, but we can't classify them any further. These cells will have a typically granular cytoplasm, round to oval nuclei with generally nucleoli. Cells lack features of high-grade lesions, such as marked nuclear atypia, high mitotic index or activity, or necrosis. So you're going to see these, but you're not certain what to do with them. Here we can see a lot of oncocytic changes with the crystal structure, but the oncocytes are changing, are enlarged, and they can be variable in size. What do you do with these things? Is this benign oncocytic changes? Is this oncocytoma? Could this be a malignancy? Don't know. This is where the classification comes into play. Again, go to the website. There's a lot more images that will help you get a better expanded idea of this. Unfortunately, time constraints again limit me. And the last one we're going to talk about is clear cell features. This is a fairly uncommon one. I've personally never seen this one, at least not. But basically what we're looking at is cellular aspect without cytomorphologic features of a specific neoplasm. But you see all these cells with clear cell, with low to moderate NC ratios, with the absence of high-grade features. You see all this bubbly cytoplasm. What are they? Well, my first look at this is Essner cells. Maybe that's what they were. Don't know. There's big sheets of them. They're single cells. They're a bit variable. They're not real high NC ratios, but they're certainly more than you might sometimes see. This is where these clear cell feature components come into play, and this is where this classification comes in. Okay, so those are the three kinds of types of entities we'd be looking at for SUMP. Okay, suspicious for malignancy. Used to stratify the risk of malignancy and to inform the treating clinician that a particular specimen cannot be placed into more specific benign or malignant diagnostic category due to diagnostic limitations such as sparse cellularity or various specimen artifacts. We are limited by the quality of our sample. And please do not think the clinician or whoever is collecting the sample is incompetent if they get a sample that has artifacts. It happens. Even into the best of people, you're going to occasionally have a sample that has artifacts with it. So this is one of the reasons why I think it's so vital to have cytotechnologists or cytopathologists at sample collections. Cytopathologists are way too expensive, so cytotechnologists probably would be the place to go. But you handle these samples badly, and you really compromise the effectiveness of the entire procedure. So I am a strong proponent of having cytology laboratory assistance when samples are collected. My commercial's over. Okay. So I think we've talked about most of these before. So I'm going to skip the rest of this and get on to what we're looking at. Aspects of salivary gland FNA leading to the interpretation of suspicious for malignancy include marked atypical cells with poor preservation, artifact of fixation, obscuring inflammatory cells or blood, presence of limited cytologic features specific for malignancy, just a sparse aspirate. That has happened sometimes. Presence of markedly atypical or suspicious cytologic features in a subset of cells, but admixed with features of benign salivary gland tissues. Atypical features may include prominent nucleoli or macronucleoli, nesonucleosis, increased nuclear to cytoplasmic ratio, nuclear molding, prominent nuclear pleomorphism, atypical mitoses, and clumped coarse chromatin. Scan cytoplasm and atypical features suggestive of neuroendocrine tumors as well. Neuroendocrine neoplasms can occur here. Ancillary testing is critically important. I couldn't make that any more bold. You've got to have the ancillary feature testing here as well. No longer can cytotechnologists operate in an island and saying we don't need anybody else to help us. We do. For the best diagnoses for the patient, get familiar with these ancillary testing opportunities. They can create a much better final diagnosis for the patient, much more accurate. Okay, here we've got a small cluster of cells. It's poorly preserved. You can see a lot of debris and necrosis in the background. What do you do with this? This preservation is horrible. But these cells are in clusters, and boy, they don't look very good. They're eccentric nuclear positioning, things like that. So this is atypical. Nah, I think we go with suspicious on this one. Suspicious for malignancy. A differential diagnosis of lymphoma can occur here. You've got to look at that. What is this? So you get a lot of lymphoid material. What are you going to call here? So you're going to see a population of enlarged atypical lymphocytes. You're going to see a monomorphic population of lymphoid tissue. They may be smaller, intermediate in size. Or you can see a heterogeneous population. It can be marginal cells, exosonal marginal cells. So here we got a lymphoma. Look, is this lymphoma? I don't know. I think it's lymphoid tissue for sure. You got lymphoglandular bodies in the background, so you know you've got some lymphoma. So what do you do with this? Now, there's a flow lab someplace around the corner. Wouldn't be a bad idea to think about them. There's other immunotests we should be doing. You don't know for sure. You don't want to write it off as just inflammatory cells. There may be too many of these cells to just write off as just some a chronic inflammation. So you're going to look at these and you're going to say, what do I make of this diagnosis? This is where suspicious comes into play, and you apply ancillary testing modalities. So those are some of the reasons we can use suspicious category. I think it's a difficult category to get your head around because I'm so fond of saying that the transitions are the hardest part about cytology. It's really nice when something is clearly benign or clearly malignant. And all these atypias and suspiciouses, how many cells do you need to see to consider it suspicious versus malignant versus atypical? Experience will be your best teacher here. I think the reporting system gives you some very good ideas on how to start, but I think it's going to be something we're all going to have to sort of get some experience in using to really become as effective in its application as we would like. So read the book. It's a great way to start it. I think after you do a few more aspirations, I think you'll get a little better at this application. Okay, malignant. I did get them. How much more time do I have, Josh?
I think we have at least a half hour if you really want to use it.
Good God, I've been going too fast. I'm sorry for going as fast. I was trying to get through this quickly. I should be able to get through most of the malignancy then and still have some time for the question and answers. Low-grade malignancies, low-grade carcinomas. Actinic cell carcinoma is classified as such. It's about 10 to 15% of salivary gland malignancies. Second most common salivary gland malignancy after mucoepidermoid carcinoma. It's about 1/3 of pediatric salivary gland carcinomas. Usually seen more frequently in women. Mean age of detection, however, is 50, so may have the young kids, but then it gets a little, for not people your age group, more people my age group or older. So we get to that stage. Most commonly occurs in the parotid. It's a mobile, firm, well-circumscribed mass. Tumors are usually slow growing. The aspirate can be painful because oftentimes the facial nerve can be involved. If there is facial nerve involvement, it usually leads to a poorer prognosis. and occasionally this tumor is bilateral. So it's usually a pure monomorphic population of acinic cells without any ductal cells. So normally you see acinic cells, but you see some ductal cells as well. In acinic cell carcinoma, you do not. So these cells, acinic cells, are usually seen in loosely cohesive groupings, and you may see some fibroblast vascular cores in some of these. You can see a papillary network with loosely adherent cells with well-developed papillary formation, oftentimes a bloody background. You generally do not see any fibrofatty stroma. Chronic inflammation may be present. Some lymphocytes may be seen as well. The cytoplasm, usually you see polygonal shaped cells with abundant granular cells containing zymogen, if you're really interested, with poorly defined borders. These cells are very fragile. So if you get an extremely well-preserved sample, you might see more defined cell boundaries, but generally they're fairly, they do degenerate relatively quickly. The granules are PAS positive, diastase resistant. So you see the basophilic staining on PAP, and they're pinkish on Romanowski stain. Cells have low NC ratios. Nuclei are bland and uniform, show minimal pleomorphism or atypia. Bare nuclei or naked nuclei are relatively uncommon here. And you may even say a Samoma body. So you've all seen acinic cell carcinomas, and here's a pretty good picture of them. One's a PAP stain, one's a Romanowski stain. I try to give equal opportunity to my stains. Although I will tell you, I do have a strong preference for Romanowski stain with salivary gland aspirations. I always want to acknowledge any biases I have up front, but I do tend to serve like the Romanowski stain. But we can see the more abundant cytoplasm that these cells do have. But notice the lack of ductal cells. You don't have anything other than acinic cells. And that's a characteristic feature of this tumor. So how do you differentiate them from benign? Well, generally you only see a lower cellularity with the benign process. You also see the ductal cells. You may be seeing some fatty stromal cells as well. You may see serous or other mucinous types of cells. The acini are very well formed with benign nuclei. The acinic cell carcinoma have a higher cellularity. You may see the bare nuclei as well. You don't see ductal cells. I should have made that one bold with lots of exclamation points. No stroma, no fatty stroma. You may see some various shaped acini. They're not going to be the normal round and uniform ones, and there may be some slight nuclear atypia. I have not found nuclear atypia to be a big diagnostic feature in most of the acinic cell carcinomas I've looked at. I wish it were. It would be nice if they had big, ugly nuclei with prominent macronucleoli, but I'm sorry they don't. No one said life would always be easy, so we always like those, but don't see them generally speaking. So that's how you can tell acinic cell carcinoma from some of the benign things. But I can't stress enough making sure if you see ductal cells, it's probably not a malignancy. Okay, secretory carcinomas. Previously referred to as mammillary analog secretory carcinoma, found most common in the parotid gland. The mean age of detection is around 47. I always wonder when they come up with those numbers. Of course, mean is sort of interesting to study. You can just look at the statistics, but we'll see how that goes. Again, this tumor is relatively slow growing. Is low risk of local reoccurrence, lymphometastasis, or distal metastasis with the secretory carcinomas. Cytologic features can include cellular aspirate, cells present singly or in tubular, follicular, or papillary groupings. The nuclei are bland. You can see cuboidal, polygonal shaped cells with low NC ratios. abundant vacuolated eosinophilic cytoplasm. You don't see the granules that we saw in the actinic cell carcinomas. Uniform, round, eccentrically located nuclei with smooth nuclear contours, fine chromatin, and a distinct nucleolus. Background is usually mucoproteinaceous material. And you see there's a genetic translocation that occurs in many of these tumors. I did not spend a lot of time on the other techniques, so I do apologize. Just not the right time and place to try to get into that. So here again, we have a secretory carcinoma, and we can see the abundant cytoplasm of some of these cells. You can see nucleoli in some of them as well. There's a Romanowski and a Pap stain present here. You can see how it doesn't look like the actinic cell carcinoma. There's more variability to these cells. There's sometimes higher NC ratio, and sometimes you have the eosinophilic look to the cytoplasm on the Papa-Nicolau stain. It is not keratin. I repeat, we're not looking at keratin. It's just got an eosinophilic look to the cytoplasm. Okay? Epithelial, myoepithelial carcinomas. An uncommon low-grade malignancy, about 75% of the time in the parotid, usually seen in my age group, 60 to 70-year-olds. Sorry, I should not just include my age group in that. It's a slow-growing mass, again, oftentimes a biphasic tumor with an inner layer of cuboidal ductal cells and outer layer of myoepithelial cells. So if you look at them, you might see two layers of cells, so it's a biphasic tumor. The aspirates look like arrangement of benign cells and pseudopapillary groupings, sheets, three-dimensional groups. It may have a laminated acellular stromal cores with these as well. Predominant population of clear myoepithelial cells, minor population of ductal cells. Background is usually bare nuclei. Again, we can see a biphasic nature of tumors highlighted by immunostaining. We'll not go into that. But here you can see that laminar core. I thought this is a really cool picture, again, from the website. So you can begin to see that they do have those, and they have nice nucleoli in some of these cells as well. So recognize this is a tumor that, again, I was not familiar with this one to start with. So this is a relatively new one on my radar. But I think the pictures in the website are excellent. So again, I keep trying to push the website on you guys. I really recommend the website in the book. It's much better than my talk. And because this is just trying to consolidate it all down into a time frame. Okay, so those were the low-grade carcinomas. Now let's talk about the high-grade carcinomas. Salivary gland carcinoma is the first one we're going to talk about. 50% of cases represent malignant transformation of pleomorphic adenoma. If you don't completely excise a pleomorphic adenoma, it can become malignant, transform into salivary gland carcinoma. Constitutes about 10% of malignant salivary gland malignancies. Most commonly seen again in the parotid, most common in men in the 70s. And it's a large tumor with foci of necrosis, generally speaking. The aspirates, you see three-dimensional crowded or cribiform groups with overtly malignant features, medium to large polygonal cells, well-defined cytoplasm, and large round nuclei, pleomorphic nuclei, anesonucleosis, hyperchromasia, and the like. And here we can see some really big, ugly-looking nuclei. I think the one on the right is a cell block. I am a big proponent of cell blocks. I think they're extremely valuable to your practice. If your laboratory does not do them, you might want to consider doing them. I think they're really worthwhile. I know that some people aren't as fond of them as I am, but I think particularly now with the advent of all these other ancillary tests, I think about being able to have that cell block there so you can make some cuts of it to do the special stains that you might need to use on these final diagnoses. But this one, salivary duct carcinoma, a lot more pleomorphic bad-looking nuclei. Oftentimes, the patient will have a history of having had a pleomorphic adenoma. Okay, lymphoepithelial carcinoma is another rare tumor. It's associated with Epstein-Barr. Almost every patient who has these tumors has an Epstein-Barr infection. You know, Epstein-Barr causes things like mononucleosis. So Epstein-Barr infections are they seem to have other kinds of effect on patients over time. So cytologic features include a very cellular aspirate with syncytial clumps or polygonal, polyhedral or spindle-shaped cells with scant cytoplasm, pleomorphic vesicular nuclei with distinct nucleoli, and abundant small lymphocytes or plasma cells in the background. When I first looked at these images, I really freaked out. I really thought, oh my gosh, this looks a lot like some of the Lisa, and you have to look at them carefully, but you have a lot more cellular pleomorphism and nuclear abnormality in this particular grouping of cells. So recognize that, to me, was the differential that I had to bring to my mind when I was looking at these cells. I'm sure you thought of that immediately as well. So I'm going to give the audience a lot of credibility here. So I'm sure you were thinking about these as well. So recognize that's the differential diagnosis I thought of when I looked at these issues. But you have a lot more pleomorphism in these than you do in just the Lisa cells. Okay. Okay, carcinoma with high-grade transformation. Small cell neuroendocrine carcinomas are classified here. A poorly differentiated carcinoma, head and neck lesions, usually seen in the 5th to 6th decade. Rapidly growing mass with a very poor prognosis. I say these things in great reservation about prognosis anymore, because it seems like every month or so they come up with something that had a bad prognosis and now has a good prognosis because they have some kind of treatment for them that have increased the survival rate dramatically. So I'm very excited. I think my generation will die of cancer. I think your generation probably will not. I think it's going to be taking 2 pills a day, and you're going to keep your cancer under control, because they're making such progress with the diagnosis and treatment of these tumors. So I bite my tongue when I say something has a poor prognosis. You see single cells in small clusters, high NC ratio, scant cytoplasm. You know the drill on small cell neuroendocrine carcinomas. They see the molding, you see nuclear streaking, crush artifacts, all the things you would normally see. And here's some really nice nuclear streaking, crush artifact, and everything that you would expect to see with small cell neuroendocrine carcinomas. So recognize they do occur in the salivary gland as well. So we have to have those in our diagnostic toolkit when we begin to look at salivary gland aspirations. Again, ancillary testing here is essential. We can have, there's so many wonderful tests, immunotests, molecular tests that can be done to verify this diagnosis and even to add more information on the patient's prognosis and treatment. Okay, now we're going to talk about cancers with intermediate or multiple grades. See, this has been reclassified considerably from when I went to school, and since some of you are my students, even when you went to school, but one thing I love about cytology is you never have to stop learning. I would hate to be an accountant. Sorry if any of you are related to accountants, I do apologize, but I just find my accountant's a wonderful man, but he's as exciting as watching paint dry. He just does not. I think there's a gene that you have to be devoid of personality to want to be an accountant. I'll go back to my presentation. Okay, mucoepidermoid carcinoma is the most common primary salivary gland malignancy seen in both children and adults. Most commonly seen in the parotid. There's a 3-tiered grading system. There's a well differentiated which has a very good 10-year survival rate. Moderately differentiated, which has got still a pretty good 10-year survival rate, and a poorly differentiated that has about a 25% 10-year survival rate. So being able to come up with some classification of how well differentiated the tumor is will be an important bit of information to provide to the clinician and then to the patient. So these are things that we need to work toward. So mucoepidermoid carcinomas is a malignant glandular element, a neoplasm characterized by epidermoid, intermediate, and goblet mucin cells, which vary in proportion depending on the histologic grade. Epidermoid cells are squamous in appearance, but they're not keratinized. They look squamous in appearance, but sometimes they look orange, but that's not keratin. Intermediate cells are columnar to polygonal in shape, occurring in flat sheets and have high NC ratio or higher NC ratios than the epidermoid cells. You see these in the sheets of cells that you see in this particular tumor. Mucin cells can be abundant in vacuolated cytoplasm. So many times these cells have lower NC ratios and have an eccentric nuclear positioning. So when you see these mucin cells, they can be really distinct goblet type of cells, or they can be cells that have fine mucin vacuoles in their cytoplasm. So low-grade mucoepidermoid carcinoma, aspirate usually contains mucinous, squamous, and intermediate cells. Mucinous cells are more common. So you see in the low-grade mucoepidermoid carcinoma more mucin cells. They can appear benign, which is really the frightening thing about it, that these cells don't look overtly malignant in some cases. They have finely granular vesicular chromatin and have cytoplasmic vacuoles. The loose clusters and sheets have a gradual transition from mucin-producing cells to intermediate cells with a slight amount of nuclear atypia. There's a cystic background may have abundant extracellular mucin in these cases. You may also see oncocytes, clear cells, and columnar cells. This can be a very common cause of false negative diagnoses because, they don't look bad. There's nothing here that looks really abnormal. Mucin is your clue. Mucin is not what you're looking to find. Differential diagnosis can often include mucocele or cyst contents. Here's a low-grade mucoepidermoid carcinoma. You can see these mucin vacuoles in some of these cells. They do not have extremely high NC ratios. The cells on the right, you can see some intermediate cells as well as mucin-containing cells. The image on the right, the mucin-containing cells do not have large, I have a 10-minute warning. Okay, I'm going as fast as I can and get as many malignancies covered as possible. You can see the mucin is finely dispersed in those cells. Notice how the cytoplasm's got a slightly pinkish color to it. So mucin isn't always the big discrete vacuoles that we always like to think about. Here's another low-grade mucoepidermoid carcinoma. You see some mucin in the background. I thought that was important to stress. You can see the mucin in the background in these cases. Again, the cells do not look exceptionally abnormal. For those of you who are looking for big, ugly nuclei with prominent macronucleoli, this is a tough diagnosis. Okay, moderately differentiated mucoepidermoid carcinoma. This is one of the reasons. Look at this beautiful picture. Notice how the PowerPoint spaced all my words in here. And I tried for 5 minutes to figure out how to fix it, and finally I said a 4-letter word and went on with it. So I apologize for it. Every so often, Bill Gates does this to me, and I don't know why. But here we have more nuclear atypia than in the low-grade mucoepidermoid carcinoma. It's still bland, cohesive, crowded sheets with well-defined intracellular borders, but there's a higher NC ratio than seen in the epidermoid cells. Again, the shift is going from the mucus-containing cells to more epidermoid cells as we move along. So you're going to see in the moderately differentiated tumors a decreased number of mucin-containing cells and increased number of the intermediate and epidermoid cells. Subtle, but that's what you're going to be looking at. The high-grade mucoepidermoid tumor aspirates contain higher malignant squamous cells with glandular elements not prominent. So you don't see many glandular cells. You see a lot more epidermoid cells. You can see necrosis. You see pleomorphic cells with dense cytoplasm and with rare glandular cells. Cells in crowded sheets or clusters and significant amount of nuclear atypia. They're generally solid tumors. Glandular element is not prominent. If you see a lot of glandular cells and a lot of mucin, it's probably not a high-grade tumor. Here we've got a lot more pleomorphism, a lot more variability in these cells. Again, thanks to the Mayo Clinic for this image. We can see these cells having a lot more enlargement and variability. Here's some more cells that we can look at. We can see they're epidermoid. There's more polygonal shape or polyhedral shapes to these cells. Again, this is what some things we're going to be looking at. Here again, it's a lot more nuclear abnormality. They're bigger nuclei. We can even see nucleoli in some of these cells. Again, in Romanowski stain, nucleoli are not red. Okay, we don't want to have that misconception. I say that a lot, and people say, well, they're not red, so well, never mind. Okay, here we have some more high-grade mucoepidermoid carcinoma. Know how it looks much more polyhedral or polygonal in shape. The nuclei are more variable. You would be probably willing to call this something like carcinoma in situ or high-grade dysplasia, possibly, if I were looking at this in a GYN analog. This is what I see when I look at high-grade mucoepidermoid carcinoma. I think that the high grades are not hard to diagnose. The low grades are not hard to diagnose once you get past the viewpoint that they don't look highly malignant. The intermediate ones, I have to admit, they're a little troublesome. But I think that if you can get more experience, go back and look at slides. Go review this website. The more practice and experience you get with them, the better you'll become at being able to make these differentials. Adenoid cystic carcinoma, again, there's a lot of, historically we're called cylindromas. I don't know why I have that in there. Again, we're looking at uniform epithelial cells, the bland nuclei and acinar formations. You see holes in them. They're slow growing, but this is a relentless tumor with a long-term poor prognosis. Had a student about 5 years ago, her mother had this tumor. And she took a special interest in this unit. Probably more interest than any student I've ever had. This is not normally high on your hit parade, and I want to learn salivary glands, but we'll go. So adenoid cystic carcinoma, again, it's a 4th to 6th decade. Most common in submandibular gland and other minor salivary glands. So it's not as common in the parotid. It's seen someplace else. Slow growing, often leads to paralysis, facial paralysis. Often reoccurs after surgical resection. We all seen these lovely little hyaline nodule globules that these things have. It's mucinous material that stains pale blue with PAP, pink with PAS, and magenta with Romanowski stain. So choose your stain. The cells are often seen, nuclei can be somewhat angulated, and the groups may be variable in size. So a lot of the same criteria. I'm running out of time, so I'm going to go quickly through this to leave time for questions. We've all seen these lovely little groups of cells with where they have the hyaline globules in the center and the cells generally around the periphery cytologically. This is what they look like. It's a pretty classic characteristic present. So when you see these, I think for the most part, what makes the diagnosis. You can have a solid variant. I threw this only because I couldn't wrap my head around this one. Where's the hyaline the globule I want to look for, and it isn't there. So here's some more of the same. Here we can see the hyaline globule in this particular one. It's down towards 6 o'clock. See some cells wrapped around it. High power view, aren't they pretty? You've all seen them before. I get it. When I see something pretty, I throw a lot of them in. That's just the way it goes. Here's a nice magenta stain to them. I like that. Okay, some more adenoid cystic carcinoma. I think I'm getting tired of this. Okay, myoepithelial carcinoma. Let's move right along. Do I have to stop for questions? 5 minutes. I'm doing well. Will I have still time for questions, Josh? Okay. Okay, this is a myoepithelial carcinoma, is a rare tumor, most commonly seen in the parotid. The features include it's a cellular aspirate, neoplastic cells arranged singly in small clusters, sheets, or crowded groups, metachromatic stromal material in variable amounts, plasmacytoid, spindle, clear, or epithelioid morphology, intranuclear pseudo inclusions can be seen, as well as a moderate amount of glycogen-rich cytoplasm. So here we can begin to see some myoepithelial carcinoma. The low power view on the left, you see what appears to be some myoepithelial cells with stroma in the background. The right is the higher power magnification. You've got some significant nuclear abnormality here. So this is what they look like. I personally have never seen one. So if you ever see one, I always say this at these meetings, remember the School of Cytotechnology. See if you can get some extra slides and send them to us. We certainly like taking any contributions people can make of really unique and rare cases. So it certainly helps to have this material. I have personally never seen it, but this is what the myoepithelial carcinoma looks like. Carcinoma pleomorphic adenoma. It's most commonly seen in the parotid. It's again a highly cellular, high-grade carcinoma, resembles its focal component of pleomorphic adenoma. Don't have any pictures. There's hematolymphoid tumors, so you can have non-Hodgkin lymphomas. You can be seen there, B-cell lymphomas, low-grade B-cell lymphomas. Low-grade B-cell lymphomas, you have the characteristic features I've outlined here. Again, you can see these tumor cells. I'm not certain that I feel we can say on FNA of a salivary gland that we can make the clear diagnosis of what kind of lymphoma we're looking at. Remember your ancillary gland or ancillary testing, friends. It certainly helps. I mean, I know that people say we should be able to try. I think we should. I certainly can say we certainly have lymphoblasts and immature lymphoid tissue here and lymphoglandular bodies. So, but I do believe we would want to get some, the ancillary testing is invaluable in these cases. Okay, last but not least, secondary malignant tumors. These from all sorts of things that can be metastatic to the salivary gland. These are usually cellular aspirates and are usually high-grade tumors with cytomorphologic features depending on the tumor type. This is this plenal ordinary adenocarcinoma. They can't classify it any further, does not fit in the recognizable groups. There's a lot of immuno and things like that we can be doing now to begin to identify what the origin of these tumors would be, whether it be a primary tumor or a metastatic tumor. Rarely you can see squamous carcinomas metastatic to the salivary gland or even arising in them. Here we can see this irregular chromatin pattern, chromatin clearing, thickening of the nuclear membrane, and other features that are characteristic of squamous carcinomas. I think nucleoli are also present in some of these cells. There's that cell-in-cell formation, oftentimes seen in, not oftentimes seen, not sort of rarely seen, but often photographed presentation for squamous carcinoma. I think that's a better way of putting it. Melanoma is the last thing I want to talk about. Melanoma can be very easy to diagnose if you have melanin. And unfortunately, there's a lot of the metastatic melanomas that do not seem to contain as much melanin as we would like. Again, there's wonderful immunostains that can be useful in this process. So if you have a salivary gland aspiration that gives you this sort of very malignant appearance, but you're not certain you can classify it any further, and the patient has a history of melanoma, it's certainly to keep your eye on, working on toward to try to coming up with some further workup on this patient to determine if these cells are consistent with a metastatic melanoma. Thank you very much. And we're continuing with our Star Wars theme. I did get through this. I'm amazed. I went really fast. I do apologize for the speed, but I was hoping to try to cover as much of this as possible. Questions?
Yeah, thank you, John. I thought your pacing was perfect, and we do have a couple of questions from Facebook Messenger and through the GoToWebinar app. We have one over Facebook Messenger from Anthony, wondering about the materials you mentioned through Milan. Is that only for folks who have purchased the book, or is that a website open to the public?
Website is open to the public.
All right, we
Okay.
will
If
provide
the
a link.
website was listed in the first or second image.
Okay.
So I have it in there. I really recommend it's open to the public. You don't need to buy the book to get access to it. Use it liberally. It really will help.
And the other one is about another place you mentioned, some images from Mayo. Does Mayo have like an educational program or something regarding salivary? Or is that just an image from their?
That's just an image from their school that they were nice enough to share with us.
All right.
We were sharing images with Mayo for some time early on. We had a good relationship with them. It's a great program up there. And we were, if we had something we didn't have any good images of, we'd call them, and same vice versa. We'd send images back and forth.
Great.
But I don't think there's anything unusual about that. We just make sure we give credit to them when we use their images.
All right.
Nice to acknowledge them.
So those are the only two. Do we have questions from the in-person audience and anyone who's still on with us? We still have several attendees on. If you can send me anything, but it's like we have one. I can pass. Yes, John's PowerPoint will be included in the download. All the materials that you see live will be included, and then we will do separate PowerPoint links, and we will probably have to do maybe a little bit more adjunct material. We'll have to see.
Right. And as a plug, I do recommend if you do talk to your lab, get the book in-house. I think it's well worthwhile. I think the book has an awful lot of useful information that's not just on the website. So I do recommend. I do have a copy of the book with me if someone wants to take a quick look at it. I decided to bring it with me. I do not get commissions for selling these books either. So.
All right. So thank you very much, John.
Thanks, everyone.
Yeah.
Thank you for being here.
Yeah. All right. I should be able to wrap up. We have one surprise announcement to make before I get into saying goodbye. As many of you probably know, the ASCT and ASCT Foundation is holding a meeting concurrently with this one. I did receive a couple of emails regarding that, but May 4th is technically my day, so we decided to hold it today, and those who are over there can listen to this, downloading it after the fact. But they announced awards today, and one of our members, Shanghong Yi, received the Holmquist Cytotechnologist Achievement Award today. So some applause for that. And now Kaitlin was able to make it all the way from Milwaukee, so we're glad to have her. If you go back and you download the webinar, we did a little thank you to you, so I'd like to repeat that one more time. Thank you so much for all your contributions, and we look forward to bugging you in the future. And most importantly, thank you to the membership. I don't know if we do as much as we can to thank our members. It wouldn't be a society without membership. So, if you feel like you haven't been thanked, here's at least one for you. We couldn't do this without you. And may the 4th be with you. I'm glad everyone was able to come out, and I hope the Lucas and Disney doesn't try to sue us for using all these gifts. Thanks everyone for coming out, and have an excellent weekend. Thanks again.
And thanks to Josh for putting this on. I know a lot of work goes on.
Don't forget IT. Jim.